units, and especially my great friend Tatiana Belin that helped a lot for this presentation. So today we will talk about cardiotoxicity evaluation in a patient with recidivant breast cancer and structural heart disease. We have no conflict of interests. So I will start by the case report. It's a female, 50 years old, with a history of rheumatic fever in childhood. And there were some episodes of atrial flutter requiring external electrocardioversion in 2006. And she was necessary to replace mitral and aortic valves by mechanical prostheses in 2007. By the year of 2015, she had the diagnosis of breast cancer. It was an infiltrating ductal carcinoma, estrogen receptor positive, and HER2 positive. Here we can see the oncologic history of this patient, and in this way, I think it's better to understand it's a complex case. So in 2015, there were the breast cancer. It was required to do neoadjuvant systemic therapy with anthracycline, docetaxel, and trastuzumab. After that, in 2015, radical mastectomy and resection of axillary lymph nodes. She was a patient that had her treatment in Instituto Nacional do Câncer, and after that, the adjuvant systemic therapy was done by trastuzumab, anastrozole, and she required to do also adjuvant radiation therapy. In 2018, there were malignancy-related superior vena cava syndrome, and then it was necessary to start trastuzumab, continue the trastuzumab and palliative tamoxifen since February 2019. This patient was treated also at Instituto Nacional de Cardiologia, and in 2020, this was the treatment, oncologic treatment. It was since May, trastuzumab, pertuzumab, and vinorelbine. By the end of March 2020, she was admitted there, ambulatory care with palpitation and NIHA 2. It was dyspnea, and she was at that time with medications as metoprolol, furosemide, and warfarin. On April, she was admitted at the emergency department with progressive dyspnea, exercise intolerance, and palpitation, and worsened her functional class. Her electrocardiogram, it was an atrial flutter, and it was associated amiodarone. By this time, her left ventricular systolic function was normal. This is the chest radiography, just like the valves, we can see the both. There were no congestive. It's just to see these valves. This one is the electrogram. On this day, she had this electrogram. It was sinus. Her left atrium was enlarged because of the rheumatic disease, and she had also flutter and atrial fibrillation, but on this day she was sinus. On June, it was the echo longitudinal strain, 14%. There were a drop in ejection fraction of plus 10%. So I saw her and started the bisoprolol and enalapril. And after that, changed for losartan because she had cough as a side effect. After 3 weeks, she improved a lot of congestive symptoms. And then we repeated her echo with longitudinal strain, and there was an improvement. It was the same operator, the same machine. After that, Alex will show you better. So just, we can say it's just a summary. It was a female, 50 years old, rheumatic fever, prosthetic valves, hair positive relapsed breast cancer with a chemotherapy associated cardiotoxicity. Okay, and now I will pass for Alexi. We will continue the case with the images.
Okay. So good evening. I want to thank all organizers for the opportunity to join you today and discuss this case. I will share my screen now. Okay. In summary, the myocardium of this patient have survived a variety of aggressions like rheumatic fever, radiation therapy, previous anthracycline use, arrhythmias, and cardiac surgery with mitral and aortic valve replacement. At baseline of present chemotherapy, she had an ejection fraction of 68% and a preserved myocardial strain of 21%, as you can see here on the center. Can you see my screen entirely? Okay. Okay. At baseline, both mitral and aortic mechanical procedures had no signs of dysfunction with normal transprostatic gradients. On the center, we can see clearly the normal mobility of the mitral discs. In April 2020, despite a worsening functional class, myocardial function was normal, as Milena said. And in that occasion, atrial flutter was detected and treated, but this was a red flag for a close follow-up of this patient. Based on guidelines, we must be aware of early alterations of left ventricular systolic function in order to prevent further myocardial damage and to adjust chemotherapy, starting heart failure treatment at the right time. An ejection fraction drop of greater or equal to 10% below lower limits of normality in this patient, 53% for women, or a global longitudinal strain drop of more than 15% compared to baseline, are well-defined signs of cardiotoxicity. Although its many advantages for a first-line diagnostic tool, echo has its drawbacks and some limitations. It depends heavily on image quality, operator skills, and some technical important details for strain analysis. For ejection fraction monitoring, we have to use the best technique available in our lab for each patient, and TD echo has the best accuracy and reproducibility. In patients with limited acoustic window, the use of contrast echo is very important. For strain analysis, it is never too much to emphasize important technical issues that may influence results, and to avoid bias, it's recommended to use the same machine, the same analysis software, acquisition and analysis made by a trained operator, and very important for breast cancer patients to use a similar window for comparison, as patients may be scanned before and after mastectomy, for example. Going back to our case, after atrial flutter episode on April, we followed the patient very close, and 2 months later, we repeated the echo that showed significant drop of ejection fraction to 51%, and an important reduction of global longitudinal strain to 14.3%. And as Milena said, heart failure treatment was initiated, and we repeated echo 2 weeks later, maintaining oncologic therapy. And as we can see here, there was a recovery of ejection fraction to 57%, and global strain was improved to 17.4%. And on the right, we can see 3D multiplanar left ventricular short axis cut planes confirming the ejection fraction recovery to a normal left ventricular global function. And when we display side by side pre and post heart failure treatment, we can see a significant recovery of 2D strength, showing a relative improvement of 21.7% of global strength values, showed by a parametric representation from bullseye, where more intense red is codified as more deformation. Indefinitely, a good result of optimized heart failure treatment for this patient was achieved. Now, Dr. Aurora Isaa will make a discussion about this case. All right, can you hear me?
Aurora, we cannot hear you. I think your microphone is muted.
Sorry.
Yeah.
Can you hear? Can you see the slides?
Yes.
Yes.
Okay, just a minute. I just have to. Okay. I just bring some data to our discussion. This is a patient with rheumatic heart disease. This remains a major cause of cardiovascular disease in developed nations like Brazil, although its prevalence has declined sharply in industrialized countries during the last century. The patients with HER2 positive breast cancer, it's still a special concern, cardiac health in this patient, as both chemotherapy and HER2 target therapies can cause cardiotoxicity. I just brought maybe the last available data published to support our discussion. This document from the European Journal of Heart Failure, from the Cardio-Oncology Study Group of the Heart Failure Association of the European Society of Cardiology in collaboration with the International Cardio-Oncology Society, that show us how to stratify the patients before HER2 target therapies. And this patient should be included as a median score patients based in the data that she had anthracycline before HER2 target therapy. Here are some examples of patients and the difference from primary prevention and secondary prevention. This patient, she has cardiovascular disease, but she doesn't have a low ejection fraction before the treatment. And she has a second cancer, recurring cardiotoxic cancer therapy. So we can see her in these 5 examples. The document brings us the importance of see the factors like medical cardiovascular risk factors, lifestyle cardiovascular risk factors, use cardiac biomarkers, the previous cardiotoxic cancer treatment, and the presence of previous cardiovascular disease to risk stratify the patient. These documents in these patients say us that in patients with HER2 target therapies, standard surveillance according to the product license includes echocardiography as baselines with 3D left ventricular ejection fraction and, if available, global longitudinal strain, and every 3 months during therapy. this other document that has been accepted for publication. Tell us about the role of cardiovascular imaging in cancer patients receiving cardiotoxic therapies from the Heart Failure Association, the European Association for Cardiovascular Imaging, and the Cardio-Oncology Council of the European Society of Cardiology. Assessment of cardiotoxic risk, she would still be included as a medium risk about the data of anthracycline before followed by trastuzumab, and the surveillance, the echocardiographic surveillance of this patient. She should have a baseline exam, and then every 3 cycles, and then if stable, reduced to 6 monthly. With this data, we bring some points that we think maybe could be discussed in these patients. Discussion about the traditional risk factors that sometimes we can't include some patients. These patients we can say about rheumatic heart disease, that's very important for us. Discussion about how to evaluate this patient. We see that her global longitudinal strain of 2 months was done and was performed, and was very important to identify the difference from the previous exam, and the discussion about if she should have any different treatment for her cancer. We'd like to thank very much for the opportunity to the Cardio-Oncology Society, to Stephen, to GBECO, Grupo Brasileiro de Cardio-Oncologia, especially to Veronica, a photo from our institution. We are specialized in cardiology, so this patient, she had all her cardiologic treatment at our institution, her surgery, all her outpatient treatment, her exams, but the cancer treatment at Instituto Nacional do Câncer. Thank you very much. Maybe should we go to some discussion about the case?
Yes, if there are any questions, I think Janet, I see Janet Selly.
Can you hear me?
Yes.
Okay, thank
Yes.
you very much. Thank you, Steve, for organizing this, and thank you so much, all of you, for an excellent presentation. I did want to just ask, with the ejection fraction being normal initially, and then 2 months later, that's a significant drop down to 51 in the minus 14.3. But was the patient symptomatic that you decided to get the echo earlier, or was it because normally we do them every 3 months, and that's it's a really great catch. I'm just curious about that.
Yes. Milena is the one that saw the patient. She can tell us more, but the echo was done because of her symptoms. Isn't that, Milena?
Yes, we decided to do this trend. We had the echo done by April, and it was really normal, but she was symptomatic. So we really take into account her symptoms. And then I said to Maria Helena, I think she's here. I hope so. That she's doctor of that see her for years. And then I said, let's do this trend and let's change the medication. And so that we do this. And then by the oncologic treatment, in the initial, I said, okay, we can change the medication, the cardiology medication, but we needed to maintain the therapy, oncologic therapy, because it was a recurrent, relapsed cancer in a woman, a young woman, 50 years old, that had an aggressive cancer, breast cancer. So is that.
Thank you very much.
I have a question. I'm sorry.
Oh, I saw Alex Pereira.
Yes. Hi, Stephen. Alex.
Hello.
Who's the echo guy? I didn't understand that. Is Alex Fellix?
Yes.
Yes.
Okay, so the questions go to Alex directly. Alex to Alex. This has a double valve replacement, and she doesn't have any more subvalvular apparatus in the mitral annulus. How this influence the strain? I mean, can you still get a strain from a girl without a mitral valvular apparatus, subvalvular apparatus?
That's a good question, because we have very few papers about this patient, almost none literature about this kind of patient, even for strain, not talking about cardio-oncology, but also for strain. That's the patients that we excluding all studies that you perform usually. But in our daily practice, we see that these patients can be analyzed by strain, and maybe just to put your ROI a little bit away from the annulus, and also to try to get these patients in a follow-up, because maybe if you have a patient with 18%, maybe some influence about the mitral valve replacement. But when you get a patient with 18% and then it goes to 13%, that's important, because the baseline of this patient was maybe the best index to follow. But I know that some patients, we have some difficulties, and strain is very dependent on some technical details. But yes, we can scan these patients, and many of them have normal strain values, just to be aware of these technical issues that and problems that we can have with this technique.
Okay, and I understand that you made this evaluation in sinus rhythm, right?
Yeah.
Okay, she was on amiodarone.
No, she started amiodarone later.
During this analysis, she was off drugs, off antiarrhythmic drugs.
Maybe yes. I don't know. Milena, she maintained amiodarone for 3 weeks or months later.
What I'm asking you is
that
we changed amiodarone for bisoprolol.
Okay.
Okay.
Okay. So during the echo time, she was on bisoprolol.
Yeah, the second one.
The second one. Okay. Thank you.
I would like to make a question for the, especially for Milena and Aurora. Due to the high risk of this patient in the beginning of the treatment, do you have any special way to follow with closer measurements of biomarkers, or frequently the echo, a close protocol to follow this high-risk patient? Did you use biomarkers to preview any difference?
No, Veronica, she didn't have biomarkers for following her. She had a follow-up very close from the clinician, and we saw that this patient, she was during the pandemic, Initially, we stopped the attendings at the presence of the patients, but we use a telemedicine, and this patient was included in telemedicine. We performed a head cap with the symptoms. She had symptoms, and the doctor called her, and she came to the hospital. Was saw about with her clinician. The follow-up with the echocardiogram would be done with 3 months. It was done earlier about the symptoms. Milena, would want to say anything else about this?
Just to call attention to this fact that was pandemic one, and then Maria Helena had the telemedicine, and then call her, and we saw her with symptoms, and then we do the echo, and we really work hard during the pandemic one. So it was just like that, and the patient is better.
Okay, thanks. Is there any more questions in the audience?
Veronica, maybe I have, well, I'd like to say that cardio-oncology is, our institution is specialized in high complexity procedures in cardiology. So we have a special attention to cardio-oncology in maybe in last 2 years, and we have meeting with the colleagues from Instituto Nacional do Câncer, and trying to change informations. So we really don't have a great experience in cardio-oncology, but about HER2 target therapy, I'd like to see if other colleagues or you and someone else can say about symptoms in cardiotoxicity. That about literature says that we don't see so much symptoms as we saw in this patient. This, I thought it was interesting. I don't know if anyone wants to comment about this.
If I may, can you hear me?
Yes, yes.
Okay, thank you. Veronica said about the biomarkers. I think this lady was in this system, the universal system of health in Brazil, right?
I didn't understand.
She was SUS.
Yes, yes.
Okay.
But
Yeah,
yes.
I can imagine
Yes,
how hard
public
it is
health
to get
system.
biomarkers
Yes,
in this public system. But certainly would be very helpful, I think. The second point is, since she was already with a very impressive disease like double valve, any slight modifications could be catastrophic. I mean, you just start the treatment the second time, and she went from 21 to -15 or -14. That shows how difficult it is to us to control these patients. And you, Aurora, is absolutely right when you say it's hard to do cardio-oncology. It's more than a customized therapy. You have to be aware of all these different situations, and the patient respond very different every time. We have patients with strains showing values much worse than this with almost no symptoms, and patients with a slight difference in the ejection fraction relating, showing dyspnea, showing a lot of symptoms that we don't know how to treat that.
Yes, for us it's a challenge. We fortunately have a very close relation with our colleagues from Cancer Institute. They have a lot of patients to be followed and not so much cardiologists. And I think it's very, very nice to change informations. The pandemia stopped the meetings, but we had meetings at Instituto Nacional de Cardiologia where they came with discussions, and we really hope we can be together again.
Now the patient is 55 years old, or she's 50 years old nowadays? How old is the patient today?
She's 50.
50.
Yeah.
And do you all think that's necessary to make an investigation of coronary artery disease due to so many cardiotoxic agents and radiotherapy?
No, I don't think so. There are no history of family of coronary disease, no smoking. I don't think so. There were no segmentary alterations of echo. I don't think so.
Yes, my question is because, Alex, the posterior wall remains with a very low strain all the time, even when the strain was recovered, the global longitudinal value, and the posterior wall remains in a lower model. So I was just thinking about it.
Okay, you're right. Yeah, in the segmental strain, we have some heterogeneity, but as an isolated finding, we have to look carefully to that. But maybe you have a great, you have made a great point, because this patient has, because of the previous treatment, the risk of coronary artery disease. So maybe if in the follow-up we cannot see more further.
I think this is the point, yes, that we have to think about. As she have radiation, as you said, 50 years. We didn't make an investigation only when she had surgery, but not now. And maybe we have to think about it. I think it's a very good point.
And what about the plans of the oncology for this patient now?
Milena talked to the oncologist.
Yes.
You want to say that?
They will continue the oncologic therapy, and I will see her in 2 weeks for the symptoms, and we will see her closely. And for instance, we will continue the oncologic therapy.
She got better. They were advised about she was better, and they made the option to continue the treatment.
Very nice. It's a real teamwork. Any more questions from the audience?
One more. Aurora is laughing.
Go on.
How do you think this anticoagulation need that she has would influence the cancer treatment from now on? She must have is INR of 3.5 to whatever, and now she's in a bleeding risk as high as hell. So how can you manage that?
Well, she needs the anticoagulation. I think she needs, we have a follow-up. The patients are followed very close at the institution with anticoagulation. We have almost 100 patients per day to perform their exams, and it works very well. And this patient is included in this program. I think we just have to see her more closely, but I don't know if maybe we have to have another different protocol for her. I don't know. I really don't think she needs to have a different protocol.
Well, she used the warfarin since 2007, and the cancer was 2015, and there were no warfarin accident. There were no bleeding during this time since 2015 up to today. So it's closer, and her coagulation is very well done, and she's a very smart girl. So that, and we
That's great.
see her closer.
Yeah, that's great.
Usually, breast cancer doesn't develop high risk for bleeding. Am I wrong? Because usually in the gastrointestinal system, urinary system, so I really I really don't think that warfarin is a big deal now for her. Correct me if I'm wrong, please.
I don't know too, but I think she during some time she used amiodarone. That's it's a drug. We have to have a special attention, but not about his cancer treatment. But we feel comfortable about the follow-up that we have with these patients. That's why even she already done her specialized procedure, she continue following in the institution. These patients we don't send back to the primary care. The institution has the profile to perform high complexity procedures, but we can't send these patients without being coming to the institution. The anticoagulated patients with prosthetic valves, they stay with us.
Are you seeing this girl on a monthly basis?
Milena?
The anticoagulation?
Yes.
Yeah, monthly.
Oh, that's great. That's great.
The prosthetic patients always come monthly, and if necessary, earlier. That's why, and we had a very great experience at the pandemia, because we almost 70% of the patients had a very great adhesion to telemedicine too. And then we only have about, we had before the pandemia 120 patients to the anticoagulation follow-up and per day, and now we have about 30 only, and they send the exam by WhatsApp and receive the the change that they need about the medication by WhatsApp. It was a very, very nice experience.
Oh, that's great. That's great. Congratulations.
Thank you.
Very interesting case.
Yeah, what we thought
for you.
Thank you, Veronica. What we thought was interesting is about rheumatic heart disease that is so prevalent in our country, unfortunately, yet. Obviously, the cancer, the reality, and how to follow these patients. I think we really should have done the biomarkers. We could have done the biomarkers. Probably the pandemic was a problem in this case. But fortunately, with telemedicine, she could be followed as she needed.
Yeah, that's an open question, open issue to be discussed in other situations in the cardio-oncology meetings in developing countries, because in America they don't discuss about it, yes, and perhaps another experiences in other countries, in like South Africa, perhaps someone, Stephen, has some similar cases, we never know, or here in Central America. Stephen,
Yes.
are you there?
Yes,
Oh yeah.
I'm here.
Oh, good, good. Yes, we are going to have a meeting with our Mexican colleagues in October. Perhaps we could have a special minute to discuss something about it with them.
Sure.
So, okay, so is everyone happy? No more questions?
Actually, this is Janet with one other question. I'm so glad that she's doing well. I'm curious, after she completes her chemo, how long do you feel like you'll continue to follow her from a cardiology standpoint? You know, she's on cardioprotective meds, and you'll be continuing the echoes out for a year, or will you continue to follow her for a more prolonged period of time?
We will continue for a long time. I think that's the case. And by the echo, by the clinical approach.
About the documents that I presented, she should perform the exam 6 months later, and then before we usually do every year echo from these patients that she has the valves.
Thank you.
I think she deserves a cardio-oncology for life.
Yes, never discharge. Never. Yes. Thank you. Thank you very much, everyone.
Great job.
Excellent. Great job. Yes. It's hard to work in this kind of situation, Janet. It's not easy, even with the limitations of our services, especially in our public health service. But they are doing a very good job. And telemedicine really saved the life of this patient. Yes. Otherwise, she didn't have any chance to scream. Yes.
Well, you
Thank
guys
you,
are you're an inspiration to our profession during a very unprecedented time, for sure.
Yes, yes, yes. Thank you, everyone. Thank you, everybody.
Thank you,
Thank
Veronica.
you so much.
It
Yeah,
was a
thank
great
you for your presentation.
Thank you, Stephen. Thank you, everyone, for participating. It was really, really a great honor for us. It's very nice. These meetings are really amazing. It's a great opportunity to discuss, to see what the opinions of everyone. It's very, very nice. Thank you very much.
We're looking
Thank
forward
you.
to see everybody next month.
Yeah, thank you again.
Thank you,
you.
Janet. Thank you, Alex. Alex 1 and Alex 2. Milena and Aurora. Thank you, Steve, and thank you, everybody.
Yeah,
Thank you,
thank
everybody.
you all.
Stay safe.
Bye bye.
Thank you all.
Stay well.
Bye-bye. Stay
Stay
safe.
Bye-bye.
Right.
Bye-bye.